So it's my pleasure to introduce our next speaker. Dr. Terry Gernsheimer will speak on neonatal alloimmune thrombocytopenia. Terry is really a go-to person with questions about this topic, so we're really fortunate to have her. She is a professor of medicine in the Division of Hematology at the University of Washington and the director of transfusion services there and at the Seattle Cancer Care Alliance, and is also my colleague at the Puget Sound Blood Center.
Thank you, Barb, and it's my pleasure to be your colleague. I want to thank you for this opportunity and also for really the great work that the foundation does. They really do some wonderful work, and I really urge everybody to support them. So these are my disclosures. I've consulted for Cangene, Bristol Myers Squibb, Alexion, and have received honoraria from Amgen. The objectives of this talk will be, first of all, to describe the available options for evaluating pregnancies that may be at risk for neonatal alloimmune thrombocytopenia, or what I'll go on and call NAIT. To discuss potential antenatal interventions and the management of the delivery of the fetus who has NAIT, and to review treatment of the neonate with that disorder. So I'm going to present a case first, and our questions will all be based around this case. Following an uncomplicated first pregnancy delivered at 39 weeks, there is a normal vaginal delivery, and the otherwise a healthy appearing baby girl is noted to have extensive petechiae and bruising. Her white count is normal, her hemoglobin is a healthy hemoglobin, but her platelet count is 3,000. And question number one, the most immediate appropriate action, and again, the immediate action that one wants to take. Number one, obtain PLA1 or HPA1A negative platelets. Number two, obtain apheresis platelets from the mom. Transfuse random donor platelets, option 3. Administer IVIG, or obtain a cranial ultrasound. Okay, so I guess we're kind of split here, and it's controversial, and that's great. So hopefully we'll all learn something from this. So next slide. I think that's. So I believe that is my first slide. So thrombocytopenia in the neonate can have multiple causes, but really the most common cause of early onset severe thrombocytopenia, and again, severe thrombocytopenia would be NAIT. But additional causes of thrombocytopenia that need to be considered would be the congenital or inherited syndromes, congenital infections particularly, whether or not the mother might have ITP, whether or not there was placental insufficiency or perinatal asphyxia. And in these other causes, they tend to be pretty obvious, other than ITP in the mother we would usually know about. But these babies are otherwise very sick, whereas babies who have NAIT generally are, unless there has been a big complication, are very healthy appearing. They're not febrile, they don't have low blood sugars. And so usually it's a very unexplained thrombocytopenia. So I'm going to continue this case. The mother's CBC was entirely normal. Throughout pregnancy, she had been followed. There was no family history of a bleeding disorder or of a blood dyscrasia. And both of the parents were Caucasian and of Northern European descent. The baby is healthy, afebrile, and all her other laboratory parameters were normal. And a cranial ultrasound was done and revealed an intracranial hemorrhage. So, as I mentioned, this is the most common cause of severe thrombocytopenia, and it is also the most common cause of intracerebral hemorrhage in the fetus and in the newborn. These babies are otherwise healthy, as I mentioned, and other than differences that I'm going to get into, this is really the platelet counterpart of hemolytic disease of the newborn, which we were just discussing. But what some of the differences are is, of course, that this can occur in the first pregnancy. The maternal antibody here is specific for a fetal platelet antigen that has been inherited from the father. And this occurs in somewhere between 1 in 1,000 and 1 in 2,000 live births in Caucasians. And about 60% of these are first pregnancies, and that is one of the big differences between that and hemolytic disease of the newborn, that the mother can become sensitized during that first pregnancy, which of course makes it very problematic to know that this is coming. The clinical presentation is frequently made at birth because this is the first pregnancy and so unexpected, and the bleeding will be either present at birth or within hours after birth. And again, absence of other abnormalities, chromosomal abnormalities, anything else that might explain why the baby is so thrombocytopenic. The other hallmark of this is that the babies are severely thrombocytopenic. They're usually have platelet counts of less than 20,000, and although you can see it, mild thrombocytopenia is really much less common in these babies. So there have been multiple studies over the years that have looked at what the incidence actually is, and again, we usually say somewhere between 1 in 1,000 and 1 in 2,000. The largest study was recently done in Norway, which was a population-based study where they really have wonderful access. Out of 100,000 pregnancies, they found the incidence was 1 in 1,700. So I think that probably expresses pretty well what the incidence is in at least the Northern European Caucasian population. This is usually very severe, and often, though it's transient and will resolve spontaneously, but until it resolves, we have a problem with a very, very severely thrombocytopenic baby at high risk of intracranial hemorrhage. And many of these babies do have serious bleeding. About 10 to 20% of them after their intracranial hemorrhage will have a neurologic impairment, and there will be up to a 15% mortality. Since most of this intracranial hemorrhage, we believe, happens during pregnancy, frequently before 28 weeks of gestation, we don't really know this is coming unless we already have had an affected baby, because it's been in the first pregnancy. And so, again, this is very problematic when it's found. So it is comparable to HDN, just because the mother is being sensitized against a paternal antigen. But what happens here is that the alloantibodies, like HDN, do cross the placenta and will target this paternal antigen that's been inherited. The platelets are cleared by the RE system, and the most common antigen that's involved is HPA-1A, although frequently there are other antigens that can be involved. This one is really what we see mostly in the Caucasian population, at least. The other thing is that we frequently see that maternal HLA type is DRB3*01:01 positive, which is probably a marker for immune responsiveness. So in fact, there have been studies done showing that although some women may be at risk because they are HPA-1A negative and the father is HPA-1B homozygous, without this marker, this HLA marker, they are at much lower risk of developing the disease. So there are more than 20 human platelet alloantigens that have been described. There are two naming systems. The first one was PLA, and unfortunately, people just started putting their own names on it. So there's PLA, there's CO, there's BOC, there's PEN, YUC. But the committees have decided that perhaps it would be a lot better to just use one nomenclature system. And so PLA1 has become HPA-1A. With an amino acid substitution that will give us an HPA-1B antigen. Some of these are more common in other ethnic groups, so PEN and YUC, for example, would be Asian. Some laboratories really only measure for HPA-1A, and so really what you have to be, they'll be very interested in what the genetic background is or the ethnic background is of the parents. So there are multiple testing methods that are used: monoclonal ACE, immunofluorescence, which is mostly done by flow cytometry. There are some commercial or ELISAs that are homegrown. Back in 2002, when this survey was taken, most of the laboratories were not doing genotyping. I think that's not really true anymore. Most laboratories are doing genotyping, either by RFLP, SNP, and there's actually a chip available now. And most of these laboratories are doing this several ways. We use 3 different methods when we're trying to examine one of these cases. One of the problems that we have in our laboratory when we're looking at these cases is the fact that there are other antigens that really get into the mix on platelets. Platelets carry HLA class 1 antigens on them, and frequently these women, because they are DRB3 positive and are immune responders, will be very, very alloimmunized to HLA as well. And if we're doing just a flow cytometry, we'll find that they're very reactive against Dad's antibody, against Dad's platelets, but a lot of this may be just HLA that's interfering, and we have to go further and look at specific antibodies. ABO antigens are also highly expressed on some platelets, particularly blood group A, and that also occasionally gets in the way, but much less common. So let's get back to our mom and the baby. She is demonstrated to have anti-HPA-1A or PLA1 antibodies. She is HPA-1B homozygous, and as it turns, which is completely consistent. And as it turns out, because we always type the dads, the father is HPA-1A homozygous, which has a lot of implications for future pregnancies, since this will mean that all of the babies that she'll have going forward with this same father will be HPA-1A positive. So how do we manage the baby, at least the first baby? We use IVIG, and that is effective in most of these babies. And we also give platelet transfusions, and platelet transfusions should be the first line of what we do. We've got to get that platelet count up. It could take a day or so before the baby responds to IVIG, and we really can't wait that long. We will, of course, do cranial ultrasounds, but again, that's going to be some delay. The thing we want to do right away is get that platelet count up. And early on, what we would do was give usually maternal platelets. And, of course, we have to wash those. It means putting the mother on an apheresis machine. It means that we're going to have to go through a lot of steps of washing them. And that, of course, means that that's going to take an awful lot of time. Some blood banks do have antigen-negative platelets. We happen to have a really nice panel of antigen-negative donors. However, again, with this is going to take a while. If we don't happen to have one just on the shelf by chance, we're going to have to call that donor in. They probably can't come in till the next day. We're then going to have to put that donor on a machine. So that really isn't going to be the best way for us to get that platelet count up. It's really going to take some time. So instead, people have been using random donor platelets, and frequently people are very surprised at how well these babies do with random donor platelets. You usually see a very nice increment. Some of that may be due to literally sopping up antibodies. We have to assume that 98% of these donors are going to be HLA, are going to be PLA1 positive or HPA1A positive. But they do have a very, very nice response most of the time. And so the first order of business is to get that count up, and we frequently use random donor platelets. They may have a shorter survival, but by that time we hope that IVIG is starting to work. So what happens to these babies who have intracranial hemorrhage? Frequently they are delivered early, frequently because of fetal distress. They have normal birth weight for age most of the time because they're doing well, other than the fact that they may have had a bleed. Interestingly, we were looking at this last night and trying to figure out, could this really be true? But female fetuses seem to be much less affected than male fetuses. Male fetuses are at increased risk overall of intracranial hemorrhages, so this may just be playing this out somehow. Many of these babies many of these fetuses do not survive to birth, but many of them do. And they may have a very good APGAR score, so you can see that most of them do quite well. Only 23% of them had low APGAR. They can have very, very low platelet counts, as I mentioned, and usually they don't get much above 20. Neonatal death usually occurs in the first 4 days. About 35% of these, up to 35% of these babies will die within the first 4 days following birth. But many of them do, thankfully, survive past those days and are alive and well at discharge, although, again, about half of them will have neurologic sequelae. So this is a very, very serious disease, and again, we frequently don't know it's coming until birth. So what about these moms? This is the same 43 affected pregnancies. Many of them, as I mentioned, this is the first pregnancy or the firstborn child. They may well have had a miscarriage in the past, and one would wonder whether or not that was due to an affected baby. Preeclampsia does not seem to be increased. Many of them have been delivered vaginally, but just as many who have had intracranial hemorrhage have been delivered by C-section. And in this study, and I think this is important to note, very few of these babies had had any fetal or maternal treatments prior to delivery, frequently because they didn't know this was coming or they just didn't. So 84% of the babies in this study had been exposed to treatment. So our second question, this patient now becomes pregnant by the same partner. What would be the best way to manage this pregnancy? One, by periodic periumbilical blood sampling to determine the need for therapy, whether or not the baby might have a low platelet count, and you just saw how easy it is to do periumbilical blood sampling. Monitoring by intracranial hemorrhage by serial ultrasounds, and again, we just saw how that can be done. Maternal therapy with IVIG and corticosteroids, intrauterine transfusions with platelets, or fetal platelet antigen typing by PCR. And most of you said maternal therapy with IVIG and corticosteroids. So we'll go on and see whether or not that is indeed the best. Okay. So antenatal management is basically done by prenatal risk assessment. And what we're looking for is what the prior pregnancy outcome was, what the father's antigen typing is, and it's going to be important whether the father is homozygous or heterozygous. If he's a homozygote, we know that we're going to have an affected baby if they've previously had an affected baby. We can do fetal platelet antigen typing by amniocentesis. And so that can be done, and it's one of the ways, if we have a father who's heterozygous, to figure out whether or not the mother is going to need treatment or the baby's going to need treatment. And we can also monitor maternal antibody. And one of the things that we can see with treatment is whether or not the maternal antibody is decreasing, increasing, or staying the same, and that helps us to know whether or not the mother is refractory. If we know we have a mother at risk, but there hasn't been a previous pregnancy, we can, and we know that that the father is indeed positive, we can monitor her to see whether or not there is development of antibody or whether or not the antibody is increasing. There are several ways to do this. We generally give IVIG 1 gram per kilogram per week. Some people go every other week. If it is refractory, and by refractory we generally mean that the mother's maternal antibody is increasing, the dose can be increased to 2 grams per kilogram per week. And others will use IVIG and corticosteroids, and I'll show you some of those. Fetal blood sampling is usually not recommended anymore unless we feel that we really have a baby who has an intracranial hemorrhage that we've noticed, or we're very, very worried for some reason about fetal distress. Because at least in some of the studies that have been done, there's been as much as a 6% complication rate with that. But if it's done because it's felt that it's needed to be done, intrauterine platelet transfusions can take place. And in that case, we do use antigen-negative platelets. We don't use just random platelets. We sometimes will use mom's platelets that have been previously collected and washed. And in the U.S., and this was actually an interesting conversation that we had last night, because there's been a push not to do C-sections on these babies if one can help it. If we think that the baby has been well treated, that these babies might be able to be vaginally delivered. And that is actually happening in many places in Europe. In the U.S., I think it's pretty standard to deliver these babies by C-section, which, considering our C-section rate in the U.S., which is actually a target right now by the Joint Commission, but we do have a very high C-section rate, around 30%, that it's felt that C-section should probably be done on all of these pregnancies, particularly if there has been a previous sibling who has had an intracranial hemorrhage. So how do we stratify risks? Well, standard risk would mean that there is a previous sibling who has been affected but has not had intracranial hemorrhage. And for those babies, we initiate therapy at 20 to 26 weeks with 1 gram per kilogram per week of IVIG of the mom. If there's a high or very high risk being a previous sibling affected by an intracranial hemorrhage in the 3rd trimester, if the sibling was affected in the 2nd trimester, we would use a higher dose. That's a very high risk, and therapy is initiated at the end of the 1st trimester, so very early on. And the outcome is actually quite good. By using either prednisone with IVIG, 1 gram or 2 grams per kilogram per week, you can see that the number of of babies that had a platelet count of greater than 50,000 at birth was anywhere between 60% and almost 90%. So it's very, very effective to treat the babies this way. And overall, there's about an 80% birth platelet count of greater than 50,000, which is considered a safe count in neonates. So question number 3, the patient's sister now becomes pregnant, and she wants to know if she should be screened. So the question is, do we type both the sister and her partner? Do we type the partner only? Do we type the sister, and if she is HPA-1A negative, type her partner then? Or do we not type either of them and go on and deliver therapy the way we think it's appropriate? Okay. And most of you said that we should type the sister, and if she is indeed negative for HPA-1A, then type her partner at that point. Okay. So one last question that has recently come up, which I think is very important, particularly in view of the Norwegian study, is should we just be typing all these women, every woman who gets pregnant, for the most common antigens, for HPA-1A, and if they're Asian, perhaps for PEN or YUC, which would be 4. And should we then determine whether or not these women are at risk? If they come back negative, should we then type their partners? How should we be treating these women? Now, this is an expensive endeavor, since this only affects 1 in 1,000 to 1 in 2,000 pregnancies, and about 2% of women are going to be HPA-1A negative. This is going to cost a lot of money, which everybody who's here from the United States knows is a big issue right now. But we do know that despite the fact that many of these women do present for the first time in pregnancy, many of them are immunized at the time of delivery. And so one of the studies that are going to go forward now in Norway is collection of HPA-1A antibody-positive plasma, using that sera to develop something like anti-D, in order to give these women to immunize these women and wipe up these cells at that time. Now, one of the problems is, and one of the reasons why these women are affected frequently in the first pregnancy, is that HPA-1A antigen is on the integrin beta-3 subunit, which is expressed on cytotrophoblasts, which invade the placenta. So it may well be that these women are being affected in their first pregnancy because they're actually, during placental implantation, they're actually getting exposed at that time. The other problem is that red cells are really not very activating when they're hemolyzed, whereas platelets are. And if this antibody is platelet activating, that may actually make the problem worse and make them actually go on to make more antibody. And so it's going to be an interesting trial to see. It has not started yet. They're starting to collect plasma now. We'll be probably giving them some plasma as well. But it'll be interesting as we move forward to see exactly whether or not we can prevent this. So I want to, with that, thank you, and we're going to go on back to our questions. Question number 1, the most appropriate immediate course of action for this affected baby: to obtain PLA1A negative platelets, 2, to obtain platelets from the mom, 3, to transfuse random donor platelets, 4, to administer IVIG, or 5, to obtain a cranial ultrasound. And I think most of you got that. Indeed, transfusing random donor platelets immediately, which are readily available, would be the best course of action, followed by IVIG and a cranial ultrasound to see whether or not the baby has suffered an intracranial hemorrhage. And you can see that we all changed our mind from being rather random. Okay. The patient, question number 2, the patient becomes pregnant by the same partner, who we know to be homozygous. Pregnancy is best managed by 1, periodic periumbilical blood sampling to determine whether or not there's a need for therapy. 2, monitoring for intracranial hemorrhage by serial ultrasounds. 3, maternal therapy with IVIG and corticosteroids. 4, intrauterine platelet transfusions. And 5, fetal platelet antigen typing by PCR. And just about all of you got this right. Maternal therapy with IVIG and corticosteroids. We know that the baby is going to be HPA1A positive as the father is homozygous. And we know that the previous sibling has been affected by an intracranial hemorrhage, so this is a high-risk pregnancy. And last question. Now the patient's sister becomes pregnant, and she wants to know if she should be screened. And should we type both the sister and the father of the pregnancy? Type the father only. Type the sister, and if she is HPA1A negative, type her partner. And 4, we don't have to type anybody, we'll just see how this pregnancy goes. And most of you said type the sister, and if she is negative, type her partner. I think that's the right answer. We first of all do want to know what she is, because this may not always be her partner, and we'd like to know whether or not we don't have to worry about her at all. But if she is negative, we are going to be concerned that the baby could be affected, and we'll then want to type her partner and perhaps prophylax her. And we can see that you all pretty much knew that answer in the first place, but now we're nearly 100%. So with that, I'd like to thank you very much for your attention, and I think we have some time for questions.
I'll start out with a question. Do you always use corticosteroids with the IVIG, or how do you make that decision?
I think that really varies by center, and I don't think that really the studies have shown a big difference. A lot of people like to avoid steroids because of the risks of hypertension, of gestational diabetes. So a lot of places do not. It's really by site, but I don't think that the studies have shown that there's really a big difference.
Yes.
Antonis Katamis from Athens, Greece. Thank you for your presentation. I have a question. If most of the bleeds occur during pregnancy, is there any good studies that shows that raising the platelet count quickly enough make any difference in the long-term prognosis?
Of the babies?
Of the babies.
There were some older studies when they did this more, and this has been looked at, that indeed if a bleed has occurred, certainly it's going to continue to get worse. And so if there is a bleed, it's totally appropriate at that point to do intrauterine platelet transfusions and to start mother on IVIG, but certainly intrauterine platelet transfusions will be undertaken at that point, and they're usually delivered weekly or every other week, and there is a difference in outcome. Frequently, if you can see that there's been an intracranial bleed, that's frequently a pregnancy that either will end poorly or will end in a newborn who is severely affected.
But if we do an intracranial ultrasound and we see already an intracranial bleed, does it make a difference if we raise the platelet count in a day or 2 days? Or
it does, because that bleed's going to get worse. Okay. So you can stop additional bleeding that will occur. So certainly that would be an indication to start intrauterine platelet transfusions. Yes.
Yes.
From Egypt, Ain Shams University. The platelet cutoff level is below 50,000 to take the immediate decision to transfuse, or 30,000 if there is no bleeding or if there is bleeding. Thank you.
So I think that a lot of neonatologists will say that below 50,000 they like to treat the baby. I think that really treating the baby at less than 30, transfusing at less than 30,000 is really where you would generally really be at risk. Most of these babies are in that group. Usually, if you're above that, that's not what you're looking at. And frequently for ITP babies, for example, we frequently will transfuse them if they're less than 50,000. Some neonatologists like to wait to less than 20. These babies are usually so severely affected that there's not a question.
Yes.
Thank you for a nice talk. Friedman from Toronto. Many of these women have anti-HLA antibodies, and often concurrently. Do you think that anti-HLA antibodies can cause FNAIT?
That's been an ongoing question, and there are scattered reports in the literature where they never found an anti-HPA antibody, and there was an affected baby, and it was assumed that it was HLA. Theoretically, it could, because we certainly know that HLA antibodies can destroy platelets. We all know that from those of us who transfuse patients for acute leukemia and have a patient who's developed alloimmunization. It may be, though, in that those cases in the literature were before we had identified other HPA antigens. And, of course, when we're doing the studies, what we usually do is we take mom's sera and we test it with dad's platelets. And, of course, it's going to come up positive if they have HLA antibodies. And if it's an antigen that hasn't yet been identified, which in many of those cases that were in the literature, it was early on, and many of those antigens have been newly identified, it may be we just didn't know. So I think that's still out there. But a lot of women develop HLA antibodies during pregnancy and do not deliver these babies at this kind of a rate. And so the question is still out there, maybe, but much, much less likely, I think.
So, given that, would you, in a case where you were concerned about the anti-HLA antibody being the cause, would you treat them with IVIG and steroids, corticosteroid?
I think if I had an affected baby because again, you're going to find HLA antibodies in a lot of women who have been pregnant. And in fact, it's one of the reasons why we usually don't take plasma from women who've been pregnant. We don't use them as plasma donors because we're so worried about trolley. So if they've been pregnant, if they've had more than two or more pregnancies, we won't even take them. I don't think that if there's intracranial hemorrhage, one is going to go in there and see whether or not the baby is indeed thrombocytopenic, whether or not the fetus is indeed thrombocytopenic. If you've got a thrombocytopenic baby, you're probably going to go ahead and give transfusions at that point. I don't know that HLA would be enough for me to say, well, that's what the problem is if I can't find another antibody. I don't know that I would do that. I would be looking for other causes probably. But if the baby's thrombocytopenic, you're going to be transfusing with maternal platelets more than likely.
Thank you.
Okay, thank you.